Okay, everyone. I think people are starting to trickle in. Good afternoon, everyone. Thank you for joining us. My name is Ali Baj, and I'm happy to be here today on behalf of my colleagues at Virtual Global Spine Conference. We have an exciting session today. We're going to talk about some cervical spine cases, and as usual, this will be a interactive case-based discussion. I have the honor here of being with one of our faculty co-hosts, Dr. Jonathan Rassouli from the Cleveland Clinic. We also today have a special guest, Dr. Michael Galgano, who is a neurosurgeon upstate New York. He's going to join us as a discussant today as well, and more on that later. We have some exciting announcements we're going to make for the new year, but we'll hold off on that. Also with us is our Virtual Global Spine Conference Student Fellow from the University of Arizona, Aaron Casana. So thank you so much all for joining us. And as usual, you can always chime in and ask questions, and please be interactive via the chat box. Dr. Rassouli will be taking charge of that. So I'm going to, without delay, I'm going to go ahead and share my screen, and we'll get started. Alrighty. First things first, Jonathan, Michael, is the audio and video okay for everyone?
Seems okay.
Okay, wonderful. I'm also going to open up the chat box to make sure that I can see what people are asking and saying, but I'll rely on Jonathan to do that. Well, again, thank you everyone for joining us. Today we are going to show a few cases. This is going to be really primarily a case-based discussion on some complex cervical degenerative cases as well as cervical deformity. And so we're going to go ahead and get right to it. This is the first case. This is a 50-year-old male who has had multiple cervical spinal surgeries, about at least 3 or 4, 2 from the front, I think 1 or 2 from the back. And basically, he came in saying that somebody told him that he was fused in kyphosis, and that's why he has neck pain. On physical exam, he has no deficits. He's not myelopathic. He does not have any radiculopathy. He just has significant neck pain, and it's obvious that he has a forward posture with the head extending forward and down, and he definitely has to kind of extend his upper cervical spine and extend his neck to maintain a horizontal gaze. So we're going to go ahead and ask our guest discussant today, Dr. Galgano. Michael, when you see patients like this in clinic, what's going on through your mind? And is there a role for non-operative therapy here? Does this patient need to go to surgery right away? What's going on in your practice when you look at something like this?
So I take it he's not having any true neurological complaints, correct? This is really just a posture issue where he's kind of pitched forward and he's just having a lot of neck discomfort because he's having challenging time maintaining horizontal gaze. Is that correct?
That is absolutely correct. Neurologically, he's doing great. He's not myelopathic. I don't know if I have his MRI here, but his MRI shows no cord compression or severe stenosis. This is a neck pain issue.
Yeah, so I think a lot depends on, how much extension reserve these patients have and how much they can tolerate. Even if they're pitched forward and they feel that they could still maintain a reasonable horizontal gaze and their quality of life is not severely impacted despite the fact that the x-ray doesn't look particularly good, then I'll just treat them conservatively if they have no myelopathy, no radiculopathy. But that being said, a lot of these patients come into your clinic because they are symptomatic, right? So typically in these patients, I try to get not only upright x-rays, I'll get full 36-inch cassettes, but I'd like to get supine x-rays with a bolster underneath their scapula just to see how much extension reserve that they have.
Yeah, great points. And yeah, I mean, I think non-operative therapy, especially physical therapy, massage therapy, for the upper shoulder muscles, the trapezius, the erector spinae muscles, I think those are all important. But you're right. When they come to you, it's because they're not just uncomfortable, but they've noticed that they are, falling forward. And that was the case with this relatively young man. Now, I don't have your full AP, but here is the standing skully film. Can you tell our participants and others what are you looking for here? For example, on this, you wanted a standing skully film. Here it is. What are you looking at?
Yeah, so a few things I'm looking at. When I look at CT deformity, a couple of the parameters I tend to look at is like a C2 slope. So C2 slope should be less than 20 or 30 degrees, and this is obviously higher than that, so that's an issue. I like to look at a T1 slope as well. That should also be less than 30 degrees, and this also looks like it's probably about at least 50, 55 degrees. And the main thing I want to see in these long-standing films is to see if the head is over the pelvis. If the head is not over the femoral heads, then that tells you that they're having some degree of sagittal imbalance, which obviously he's having.
Yeah, those are all excellent points, and that's exactly right. I think the first take-home message here is that and sometimes I'm guilty of forgetting, but I'm forgetting less and less. Let me put it that way. When you see a cervical case like this, a lot of times the patients come to us with an MRI of the cervical spine, and you're like, oh well, there's no compression, you're not myelopathic, we're done. But there's really more to it than that, because these patients are pretty debilitated. So yeah, just like you said, this is I got this off online, and this is exactly how I look at cervical deformity. I tend to use the T1 slope a lot. I tend to use the C2 to C7 SVA a lot, and the Cobb angle. And for me, these really tell me a lot. Now, the interesting thing, and I think, we have a lot of colleagues like Chris Ames and others who've done phenomenal work on helping us understand cervical deformity is, we have some normal data, if you will, but, we always like to see that cervical lordosis, but we know that a lot of patients are happy with neutral cervical spines. Not everybody needs that lordosis that we always like to talk about and like to present. But the T1 slope is a big one for me. Michael, let me kind of pick your brain a little bit. How do you use the T1 slope to guide management? You mentioned that you do look at that, and I do as well. How do you use that to guide management?
So I like to make sure that if they do have a high T1 slope, which a lot of elderly people do, that's just by virtue of the aging process, that they also have a commensurate amount of cervical lordosis. So like your patient looks like they have a high T1 slope, but they have very poor cervical lordosis. So that's telling me that they're not compensating for the increased T1 slope very well. Therefore, they're going to have issues with horizontal gaze. So that's the main thing, is that if they have a high T1 slope, they've got to have a high degree of cervical lordosis to maintain horizontal gaze.
Yeah, that's exactly. Oh, sorry about that. I'm not sure what happened. Okay, great. So let's go on to Jonathan. You want to chime in, Jonathan? How do you, this is kind of a poor man's way of assessing cervical deformity here, Jonathan. What do you look at? Do you look at anything differently, or how do these parameters guide your treatment?
Yeah, so everything here I agree with Ali. The only ones I would add are chin brow vertical angle. That's, you can really only assess that either on a just kind of almost like a full body photograph of the patient, or if you're lucky and the skully series actually captures the face of the patient as well too, or like basically the front of the skull. That correlates highly with quality of life. And then it's a great paper in JNS. I'll link in the chat box, written by Blake Staub. It came out about 2 years ago, where they looked at normative values of cervical lordosis and T1 slope, and it came up with essentially, how we look at pelvic incidence and lumbar lordosis have to be within roughly about 10 degrees of each other. Just kind of the ballpark. Is this a very similar kind of equation? I don't remember it off the top of my head now. They were able to come up with in that paper. I'll link it to the chat box so you guys can read it later, but it's great. But essentially what it says is exactly what you said, Mike, is that the higher the T1 slope, the more lordosis you need in order to keep those normative values. And the converse is true. If you basically have a flat T1 slope, then some degree of cervical kyphosis or straight cervical spine is actually normal for that patient. So it's not something you have to be too aggressive about.
Excellent. Yeah, excellent. Those are great points. And I'd love to see, we have We have other excellent surgeons here in the participants. I kind of see your names there. Thank you for joining us, and feel free to chime in on the chat box. Tell us how you use these parameters. But one thing about the T1 slope that, and I agree with you guys, I think it does tell you how much cervical lordosis you want to dial in. But let me get your opinion on this. The other way I use the T1 slope, if I have a very high T1 slope, which tells me the upper thoracic spine is really kyphotic, that makes me nervous if I stop short, say T1, T2. That tells me indirectly that I probably need to basically extend that construct further down. And it's the high thoracic area is going to be a potential area for distal junction failure and distal junctional kyphosis. Michael, what do you think about that? Is that well-founded? Does that matter or not?
Yeah, I completely agree. If someone has a high T1 slope and I'm doing a CT degenerative or deformity case, I'm absolutely taking them past the apex of their natural kyphosis, which is usually down probably past T6 or T7. And maybe it's purely anecdotal, but I've had a few cases early on in my practice where I've tried to stop short of that apex of kyphosis. Fast forward 2 or 3 months later, there's a minor trauma on that bottom screw, which looked relatively horizontal after you put it in, has now kind of windshield wipered down, and then they fracture, and now they've got a kyphus below where they initially did. So I'm definitely taking them past the apex of that kyphosis, the higher their T1 slope is.
Excellent, excellent. All right, well, I appreciate that. And so let me just show you a couple of more pictures on this case, and tell me what you think. And again, for anybody in the chat box that wants to chime in and let us know how you use these parameters, definitely share that with the audience. I think I also just saw Dr. Goodwin, Matt Goodwin. If you're there, you probably can unmute your mic and tell us what your thoughts are. So let's go ahead and go on a little bit. So here's what we've got. Michael, you said you wanted supine films with a bolster just to see how flexible this deformity is. And I don't have that, but I have a supine CT, if you will, or I have a CT that's obviously done in a supine way. And so, even on a CT, this is what I'm getting. I'm getting a 39-degree T1 slope, and I'm getting almost 10 centimeters positive SVA, C2, C7 SVA. Before talking about the surgical options, what is that? And the CT confirms that he's actually fused from C4 to T2. He's not instrumented down to T2. I believe he's instrumented down to T1, but he has that osteophyte, and perhaps he's ankylosed down here. But what are these numbers are telling you? What's the SCAT scan telling you that we didn't have on the X-ray?
Well, it looks like that he's got very little extension reserve, because obviously he's laying down for the supine CT scan. And that being said, he still has a very high C2 to 7 SVA. It's probably well over 4 centimeters there. So that tells me that he's more than likely going to need at least multiple posterior column osteotomies at the cervical thoracic junction, and possibly even a 3-column osteotomy, maybe at the upper thoracic spine. I know historically a lot of people were doing C6 and C7 T1 PSOs for something like this, but the issue that I've read about in the literature is that running into a lot of C8 and T1 palsies after surgery. So I think progressively we've all, as a field, have started to move our PSOs a little bit lower to try to ward off that problem after surgery.
Got it. And again, I think Dr. Goodwin is with us, and he can unmute himself, and Dr. Selby as well, Mike Selby. Feel free to chime in if you guys want. Jonathan, what are your thoughts, Jonathan? So here are the surgical options, at least the ones that I think are reasonable or an option. What would you go with, and why?
Yeah, I agree with everything you said, Mike. He's going to probably need either multiple level, either facet osteotomies or more aggressively a pedicle subtraction osteotomy. Most likely, I agree, probably right at the cervical thoracic junction. My personal experiences with T2, because you get to, you avoid the C7 and T1 nerves, which innervate the hand. You're nowhere near the vertebral artery So that tends to be good. It roughly correlates with kind of the apex of his deformity. So my answer would likely be, and then he's fused pretty much all anteriorly. So I think going anterior is not really going to help him unless he was more flexible there. So I think I would go with either C or D. Now, that being said, you can see that probably around, I'm assuming that construct ends at where? Is that C7 or T1, or is that T2 at the bottom, the LIV?
Yeah, I think that's T1. The screw in the back there, the bottom screw is at T1.
Got it. So one level below. Yeah, I'd pick C or D. I'm a little bit worried about it. You almost see that he has kind of like almost of an apex of his deformity posteriorly is kind of at T4-ish, maybe 1 or 2 levels below T2. So I'd probably want to go a little bit below that. So I think C or D are appropriate choices. Probably in his case, I'd probably pick probably D. Yeah, it sounds aggressive, but I think I'd want to get past that T4 kyphosis in order to prevent DJK.
Got it.
Yeah, Ames or a Bowman type screw, kind of upward pointing transdiscal transvertebral body screw at the bottom.
Got it. Thank you, Jonathan. I think we at least have a few folks on the chat who agree with you. Dr. Selby is thinking anterior first. Mike, I don't know if you can, I think you can hear me. If you want to unmute yourself and tell us why you think you would go anterior, you can. Otherwise, I'd be interested in knowing exactly that, what, for the folks who want to do anterior first, what they would do. But the second question is, I think you're right, because he's fused, he's going to need a 3-column osteotomy, a PSO, and we can talk about T1 or T2. I think that everyone is favoring T2 now for the reasons you just mentioned, Jonathan. But the real question is what's going to be the LIV? Is the LIV going to be T4 or T8? Michael, where would you go? How low would you go on this? T4 or T8 or any other number? Let us know why.
I would definitely go T8. I would not stop at T4. T4 looks like it's right around that apex of this kyphosis. And I think this is DJK waiting to happen if you stop at T4. So my practice, I'm absolutely going to T8.
Okay, got it. Excellent. Yeah, I think several folks on the chat box also agree. And that's exactly right. That were my thoughts. So I'm glad some people agree with me here. I was thinking of doing a 3-column osteotomy below the construct at T2 and going long, doing C2 to T8, all posterior. I wasn't going to go from the front, but I could see a role. I could see a role for that. DEXA scan or no DEXA scan pre-op for this male, for this 50-year-old male? Michael Galgano, what do you think? I
probably would not. If it's a 50-year-old male, to be honest with you, I like to use that surrogate. I use the Hounsfield units. I know there's not necessarily a direct one-to-one correlate to the DEXA scan, but in a 50-year-old guy, I probably would not get it.
Okay. Yeah. I think, I don't remember. I think I may have ordered it, to be honest with you, but because I just, I had this algorithm, standing, upright X-ray, CT, MRI, DEXA, but I'll keep you guys posted. I think we're going to go for D, and we'll come back with follow-up on this case. So that was an excellent discussion, and I just want to recap for some of the folks with us, kind of my thought process. This is how I look at these, and I know you share, you guys share some of these as well, which is looking at the focal parameters, but not forgetting the global parameters, right? You see a lot of patients with cervical kyphosis or cervical hyperlordosis, and you're like, wow, they're so hyperlordotic. But if you take a look at the skully films, and then because they're hyperkyphotic in the thoracic spine, for example. So it's important to know what the thoracic spine looks like, what the lumbar spine looks like, because that will affect the cervical spine. And I know Chris Shaffrey once showed me a case where the surgery was all done in the lumbar, and that fixed the cervical deformity, if you will, because the patient, it was all a compensatory mechanism. So it is important to look from the top down. And these are some of the parameters we talked about: the SVA, the Cobb angle, the chin-brow angle, which Jonathan Rassouli talked about. And one of the big ones, I think, is to define the releases and the resections. which is something that I'm going to refer to in another case here. But this is something I kind of teased out on social media. This is a patient that actually came to me with this. No, she had this, and then she got extended, and then she came to me, and I said, that's why I posted. I said, the treatment for deformity, you can do a lot of things, but just extending the deformity is probably not going to cut it. This poor lady had a very poor cardiopulmonary function and ended up not really being even cleared for a revision surgery. But here's some my thoughts on this. This is actually another case that I'm going to talk about. This is a younger female with Osteodiscitis, 2, 3, 4, 5, 6. She had C5-6 Osteodiscitis, and she was actually, we can have a whole discussion about Osteodiscitis and deformity, but you keep patients in collar, antibiotics, but you have to have close follow-up, because yes, they will fuse, yes, they will heal, the infection will burn out, but you don't want them to heal in deformity, because then it just makes the surgery that much more challenging. So this is a lady that had now she was myelopathic, so she had cervical stenosis. She was fused at C5-6, but and I'll get to her pictures in a minute. But this is what I look at, and what do you guys think? So I like the MRI, I like the CAT scan, the X-rays, but each one tells me something. The MRI is going to tell me where the decompression is needed. The CT is important to tell me where the ankylosis is, and that's where I'm going to do the releases or resections. And the X-rays is for the overall alignment, and that's how I always remember this: MRI for decompression, CT for releases, X-rays for correction, and that's why all three are really important. So let me throw this back at you, Michael. This is, I believe she was in her early 50s, otherwise healthy female, with the exception that about, I think, a year and a half ago, she was diagnosed with osteodiscitis, treated with a brace, IV antibiotics. She completed the course, came to me, I believe, about 14 or 16 months later with just this terrible neck pain. And here are her scans. Here's her, for this one, I'm showing you the Cobb angle here at 50 degrees. Here's her skully films. Her SVA, her C2 to C7, excuse me, her plumb line is actually, her C2 to C7 is 7 centimeters, and here's her T1 slope. So this patient is so different than the other. Her T1 slope is quote unquote favorable. Michael, what are your thoughts on this, and how do you think this is different than the previous case based on these parameters?
Well, she looks like she's fused from the front in this case. I think the last case, he was fused from the front and back, but it's a little bit more of a focal kyphosis here. It doesn't look like that it's one of these sweeping cervical thoracic deformities. So this is more of a focal cervical deformity as opposed to a CT junction deformity. This is something that I would probably try to treat just from the front initially. And if I needed to, depending on how much bone work I did, I might supplement it with a posterior fixation and fusion as well. But something like this in my hands, I may try one of a couple of things. I might try potentially a 2-level VCR in this patient. It looks like she's got 2 vertebrae fused. And the other modality I've had some good success with is doing what I would call like an intravertebral osteotomy, where basically I just do, instead of doing a discectomy, obviously I just drill a wedge out and I put a hyperlordotic cervical cage in there. I put them in preoperative cervical traction. And if I could get reasonable realignment there, I think you're going to get decompression of the spinal cord as well. So I don't think either one of those two options are unreasonable to start from the front, but definitely putting them in traction before surgery is why I think would help them out a lot.
Okay, and what if I tell you that C5-6 is not just fused ventrally, but actually the facets, at least on CAT scan, look like they're probably ankylosed at C5-6? Would that change your opinion?
Yeah, if that's the case, if it's fused posteriorly, there's a good chance that she's going to end up needing a back-front back, right? So I would do posterior releases first, put some screws and rods. I would not tighten them down posteriorly, take her from the front, do a 2-level VCR or one of these intravertebral osteotomies with a large hyperlordotic cage. I might put one of these buttress plates on her and then flip her and then get my correction posteriorly and do multiple posterior column osteotomies in the cervical spine.
And where would you do that VCR? What level exactly? Can you tell us a little bit about that?
Is that 5-6 that's fused together?
Right.
So I would do it at that level.
Okay, so basically you would go right in the middle where the fusion is, and you'll just basically osteotomize that.
Correct.
Okay, got it. Let me see. I think Dr. Goodwin, you're co-host today. Welcome, and thank you for joining us. Again, we have some very exciting announcements for the new year, but we'll talk about that a different day. But Matthew, thank you for joining us. What are your thoughts on this? How would you tackle this case?
Yeah, thanks for having me. Sorry I was a little late getting here. I had some other clinical things going on. Yeah, this looks like a great case. I mean, I certainly agree if they're fused in the back and the front. I don't know that there's a good way to get around going back, front, back, and depending on how you want to do that and how much bone you want to take away in the front. Yeah, I mean, if that's the case, I think I'd be forced to go back, front, back. And this patient's how old? This is a younger guy, right?
Yeah, she's young. She's younger. She's like early 50s.
Yeah. So, obviously doing something at the focal deformity is what you're going to do, and how aggressive you're going to be there, I think can vary a little bit, but I don't think I would stray that far from a back, front, back here.
Okay. And how much, Matt, how much correction do you think you can get? Let's say you did back, front, back. She's 50 degrees, basically in kyphosis right now. How do you get her, can you get 20 degrees of lordosis post-op? How aggressive do you think you can get with her, with the correction?
I don't think you're going to get 20 degrees of lordosis. I mean, I think you could get neutral to a little lordotic here, but I'd be surprised if you got that much lordosis. Got
it. Thank you. Now, let's see, Dr. I don't want to show you what the plan is, but I guess I already showed you what the plan. Nader, Dr. Dadale's just joined us as well. Nader, I don't know if you can hear me or not, but what are your thoughts on this? What would you do?
I agree with the guys. I mean, since she's ankylosed, as you mentioned, like her facets C5, 6 are fused, correct?
Yes.
So you got to probably do a posterior release, put her in traction, and then go front back. So posterior release, instrumentation, and then front and then back, and lock her in. So posterior release, traction, and then a 2-level corpectomy, and then a fusion. I hope that this would be sufficient. It gets better when she lays down, but it's definitely, she's still ankylosed. I mean, she's standing up compared, that X-ray compared to the CT and compared to the MR looks much worse. So it's going to budge a little bit, but she certainly needs a posterior release.
Yeah. Nader, we think alike for some reason, but that was exactly my plan. That's exactly what I did, and I'll show you the X-rays. But I did want to ask folks, either in the participants, either in the chat box, or you guys here that are joining me in video and audio. And we had Dr. Dan Rue with us a while back when we first started this, actually back in April. But I've heard him and some others say that you can, even if the patient is ankylosed posteriorly, you can still get a reasonable correction and release with a ventral only approach. Have you guys heard that as well, or did I hear that did I not hear that correctly? And I think he showed some cases in which he can just get a beautiful correction with just a ventral release, even though they're ankylosed posteriorly. Matt or Nader?
I don't think I could. I think maybe Dan Rue can.
Yeah, I know. I mean, sure, the X-rays it was phenomenal. But I don't know if you guys have experience with that or tried that.
If it's fused in the back, I think if the facets are fused in the back, then I would do a posterior release. Yeah, sometimes you could be surprised, how powerful anterior approaches are in terms of correction, along with traction and muscle relaxation during surgery.
Yeah, I agree. Jonathan, any thoughts on this? Jonathan, what would you do?
I agree 100% with Dr. Dadale. That's exactly how I would do it.
Yeah, that was exactly my plan. I wanted to go first posteriorly, do the osteotomy fasciectomy. I wanted to put in the screws, leave my rods out, and just like Nader said, I don't think I'm as slick as Dr. Gogana here. I don't know if I would feel comfortable in just doing that, osteotomy release. In my hand, especially since she's myelopathic, I wanted to do a corpectomy, but I did a 2-level corpectomy and then brought her, same day actually, just placed the rods posteriorly. Neurologically, she did very well. She was intact. Literally one of my happiest patients. I'll show you the x-ray. I'm not as, I felt I should have been a little bit more aggressive, but I was really worried about the screw pullout. But she's really one of my happiest patients. Very, very grateful. This is just an intraoperative photograph here from the back. A C56, SPO, pretty standard, nothing too fancy there. I'll show you that in retrospect. Since I did this anyway, I probably should have done an SPO, maybe up higher as well at the C4-5 level, and I'll show you why. So here are her X-rays. I didn't get that great lordosis that I was hoping for. I got her a little, much straighter than the 50 degrees she had, but I was, with a history of osteomyelitis, discitis, I was worried about the bone quality. And I didn't want to get too aggressive with that. And here are her standing skully films post-op. I think if I did another release higher up, and maybe maybe in the front put some ACDF interbodies here, I would have gotten a better correction. But here's what she looked like. Again, she was extremely happy. I was a little bit bummed. I wanted to get even a better looking X-ray than this, but I have a saying in surgery: don't get too greedy. That's just that's just my saying. I try not to get too greedy. And the trainees know me. I have this other saying that you can have a second chance to be effective, but sometimes you don't have a second chance to be safe. So we got her. We had good motors. We had good function. So we stopped there. Nader, since you proposed doing this, what are your thoughts? What are your thoughts on this? What could I have done differently to get a better correction? By the way, she's more than 2 years out and really doing exceptionally well. What are your thoughts on this, Nader? What could I have done differently to get a better correction? Oh, we gotta unmute yourself.
I'm not sure. Maybe that's the most you can get from this, to be honest, Ali. I mean, if I would have done the same, and that would be my result as well. Maybe they'll even stopped at C2, at C3 even, not at C2. But to me, did you put an interaction in between stage 1 and the corpectomy?
Yeah, so I did this all in the same setting, and she was in Garden Well Tongs.
Okay. I think looks good to me. I think I would have achieved the same result. Putting an ACDF cage between C, so maybe what I would have done, maybe what I've done, put an ACDF, did an ACDF at C3-4, and then stopped at C3 posteriorly. That's about it. But
yeah. And
Dr.
Yam in the chat box also mentioned the same thing. Maybe a nice C3-4 inner body there would have helped and get better end plates on that cage. Just so I know, Nader, what's your choice of corpectomy VBR cages these days? Do you like allograft? Do you like expandable, static, arms cages?
To be honest, one cage is the carbon fiber / PEEK. I've used it now since I was a resident through faculty. Yeah, until now, I really like it. It's 60% carbon fiber and 40% PEEK. And I feel
any chance that has more or less bacteriostatic effect or properties? Do you worry about infections with that cage?
No, to be honest, it's like, I've used it in the setting of infections, never had an issue, to be honest. I mean, I know with titanium, it won't develop a biofilm as much as a PEEK, but yeah, that's what I use, that same old cage every single time.
What turned you onto it, or is it easier to work with, or what do you like so much about it?
I'm used to using it. I think there's a lot of room to put bone graft in it. That's what I like it. Sometimes with these expandable cages, there's not too much room to put graft in it. It depends on the cage. And, to me, it's like, if I'm comfortable with one thing and it's working okay, I stick with it. The advantages of these expandable cages, I think, are in these situations where you really want to start and try to kind of get some correction with them. You know what I mean? It's not only to fill a gap. You want to try to use them as a modality for correction, like, because they expand and you can kind of get some correction with those. So that's maybe the advantage here.
Yeah. On the flip side, they're very easy to subside. I can tell you, I can I can't remember. I mean, how many, especially in metastatic spine disease, how many, have just kind of plowed right through the end plate. So they're very powerful. And it's just like, it's that tactile feel and like, oh yeah,
Exactly.
it's fine. And before you know it, you're to the end plate. Dr. Galgano, Michael, what do you think? What would you have done differently? Would you have done more intrabodies up front? Now I went down to T4, but she had a very favorable T1 slope. Would you have stopped at T2? Michael, what are your thoughts?
Well, I think I would have done something very similar to what you did, actually, with the exception of maybe in hindsight putting a C3-4 hyperlordotic ACDF cage in. But as far as the levels that you chose, I would have done something very similar. The question I have for you is what kind of head holder are you using for a patient like this? Are you putting them in Gardner-Wells tongs, using bivector traction, or using a Mayfield, and then after you do your releases, jacking their head back? That's pretty much what I do these days, is kind of the old school Mayfield, and I have one of the residents go under the table with me while the other resident kind of mans the spinal cord and just jack the head back. But I know John Shin's a big proponent of the bivector traction, so I'm just curious what everyone here does for that, in an effort to try to get the back of the head in line with the apex of the thoracic kyphosis, which would be the goal at the end of a case like this.
Right. No, good questions. Yeah, the bivector traction is obviously very popular. It's gaining popularity. I don't think I've jumped on that yet. I've not jumped on that bandwagon, if you will. The Mayfield for me is very powerful. I use the, I don't want to say the proprietary name or whatever, but I use that joystick type of flex, C-flex type of thing where you can just joystick it into the position you want, and it's just easier than a Mayfield. I mean, it's a Mayfield, but it's just it maneuvers much more seamlessly. So I use the vast majority of cases. I'll use a Mayfield, and by pulling down on the shoulders, that gives me some traction. If I recall correctly, in this case, I probably used the Gardner-Wells tongs, but I'm satisfied with that. I don't. Let me put it this way: I don't alternate in between. In the same case, right? I stick to the same one in each case. And I rely more on perhaps the osteotomy, the laminectomy, the resections, and that way that, I'm a little aggressive with the rod, more so than repositioning the head. But that's just what I do. Nader, do you do it differently?
You do a
lot of CVJ. How do you kind of realign the craniovertebral junction?
I like to use the crown halo traction, not the tongs, bivector traction, and yeah, that's what I like to use. Now, in terms of, I think, to me, like intraoperatively with those deformity, like subaxial deformities, and as we mentioned, not upper thoracic, that's different, that's focal deformity. I find bivector traction help. I also, I would use neuromuscular relaxation too. So I would just depend on the SSEPs for that portion of reduction. And that's about it. And then listen, I mean, sometimes you can't make it perfect. I have a lot of, better, but not perfect. I mean, most of my corrections are like this, not perfect, because it's because it's all risk benefit. If you want to do a 3-column osteotomy and loosen it up too much, that's in the mid subaxial cervical spine. This is not a joke. You have the verts, you have all sorts of stuff. So I think this is an excellent result. And I mean, as you mentioned, we think alike, Yeah,
the patient, I'll tell you, the patient was very happy, and then
that's all you want. Yeah,
she's done great. Just a quick question out of curiosity: do any of you guys, would you have, let's say it's a burn down infection, it's like a year out, and the MRI doesn't show any stir? Would you ever get any inflammatory markers before surgery, sed rate, CRP, or not really? You go just straight to surgery. What are your thoughts on that, guys?
Yeah, I mean, I have before, just to make myself feel better.
Yeah. Well, what if it's high, Matt? What if you get it and the sed rate and CRP are high? Would you keep them on antibiotics and then only operate if they normalize, or?
Yeah, maybe. I might delay me a little bit. I might watch it. Or I might have them see infectious disease. I might just do an extra thing or two just to, but then at some point you're probably going to move forward. So I'd probably take an extra step or two before moving forward.
Michael, what are your thoughts? Michael Galgano, do you do sed rate CRP before every, chronic infection case, osteodiscitis?
No, I don't think it makes a huge difference, to be honest. I would probably just do an intraoperative culture right before I place one of the pedicle screws, or, you know, I'll just get access to that previously osteomyelitic bone, you know, just to have some evidence that there is no active infection. But I wouldn't let it delay the operation though.
Yeah. Okay, great. Well, I'm going to save the best for last. This is actually the hardest case in my mind. So this is a 68-year-old female. Thank you guys for those excellent discussion points, by the way. This is a 68-year-old female who remote history of C4 to C7 ACDF, and had done very well. And then now presented to me in my clinic with clear myelopathy. She's a very well-to-do person, and she's very educated. And she said, listen, I did well for a while, but now, you know, I'm having some hand weakness. My gait is off, but my balance is off. She has a Hoffman's-on exam, no focal weakness, but the tandem gait is abnormal and a positive Hoffman's. Here's her MRI. You can see she's got you know, the previous hardware, the fusion. You see a little bit of listhesis here at C7T1, disc bulge here. Here are the axials, C34, C7T1. Jonathan, are you still with us?
Yep, still here.
All right, my friend. So what are you gonna do? Your first year out here in practice. Patient's gonna come to you. What are you gonna do?
Yeah. So she never had anything done posteriorly. Huh? It's all anterior.
That is correct. All anterior. Yeah.
So it looks like she has circumferential stenosis at, or rather adjacent segment disease above and below her previous construct. Maybe even a little bit of a spondylolisthesis at C7T1 that's contributing to the ventral compression on a spinal cord, and she's myopathic. So you know, just based on this alone, I would say she's a candidate for surgery. Now the question is whether you would go, you know, you want to go front and deal with all that scar tissue and potentially put a standalone inner body above and below, but it doesn't really look like she has really any disc space there. And I can only imagine the anatomy is just horrendous and everything's scarred in on a CAT scan. I'm assuming you got more than just MRI.
Yeah. Well, what do you want to see?
I would just get a CAT scan probably.
Okay. A CAT scan shows a solid a solid fusion from the front. You know, nothing concerning on the CAT scan, solid fusion. And let's see, Dr. Barry Candelario is with us today. Thank you, John. Thank you for joining us. You know, he suggested a FlexX, and that's exactly what I'm going to show you next. And I want to talk to you about this FlexX because I think it's very interesting. So I always get flexion extensions in patients who've had previous, you know, cervical surgery for a lot of reasons. I mean, I want to see the instability, I want to see listhesis, I want to see the hardware, but I want to show you a couple of things here. Take a look at how short those screws, right? Like if today you showed somebody your ACDF with those short screws, man, they would just like hammer you like, oh, you know, what is that? Look at the solid fusion. Look at that solid fusion that you can see even on X-ray from 4 to 7. You know, so I thought that was funny. She's got a solid fusion on CT, probably good bone. You know, I'm sure they used excellent bone autograft. You can tell here, but solid fusion. But John, I'm going to stay with you, John. What does the FlexX tell you? What does the FlexX show you? You think that, you know, to be honest with you, I wasn't very impressed on the MRI, but now I'm impressed on this FlexX.
I'm looking to see if I see, I mean, she looks solidly fused at the construct. I don't really, unless I'm hallucinating, I don't really see too much movement of the spinous processes posteriorly there.
Yeah. Do you think 3-4 looks just like a little bit more? There's a little bit more maybe.
Yeah, like it looks like there's a little spondy there too. Yeah.
Yeah, I mean, you can't see C7T1 that well, but that, you know, that kind of got my attention. Michael Gilgano, what are your thoughts on these X-rays compared to the MRI? Do they tell you more or less? Do they tell you anything?
No, it definitely gives you some information. I think the listhesis is more pronounced for sure on these upright X-rays. And it looks like that, I'm not sure which one is flexion. I think the right is extension. It looks like that her disc space opens up a little bit. So she definitely has some mobility through the disc space there as well.
Yeah, no, I agree. You know, if this patient, you know, and from my perspective, let's say she had a focal C7-1 listhesis, I really think she's mostly symptomatic. I want to say from this C7, you know, T1. I would consider just treating this, but now I'm like, boy, do I just kind of extend the fusion and leave the top alone? So now let's put everybody's money where their mouth is here. Dr. Goodwin, we'll start with you. Matt, what are you going to do for this patient surgically?
Oh, I mean, they're myelopathic, right?
Yeah, she is.
Yeah, I mean, so I'm going to go in the back and do 2 to 2, open it up.
Yeah. Now, can I ask you something? Why are you going to go to C2? Why are you going to go to C2 to T2, not say C3 to T2? Just as for a question.
Yeah, because I think I'm going to go. I mean, I think we're going to go down. I think you have to address the level lower, like you were talking about. That's probably at least part of the main issue here. And if I'm going to anchor it in down to C1, down to T1, stopping with not great lateral mass screws and an older lady with not great bone makes me not super happy about that construct. Makes me a little nervous. Screws are going to pull out or something could happen. I'd way rather I don't think you lose anything by, especially with that 3-4 spondy there, right? I think trying to hold that with lateral mass screws and old bone, not a good idea. I think I'd go up to C2, get big monster screws. Yeah, and that flex shows you're going to be able to, fix her in a little bit of lordosis there. So yeah.
Yeah. Okay. So you're going to go posterior C2 to T2.
Yep.
All right. On this poor lady that just has a little bit of adjacent segment disease above and below.
Yep.
All right. I like that. I like that conviction. Nader, what are you going to do?
I mean, to be honest, I agree with Matt. I would do the same. I'll do C2 to T2, and I'll do a foraminotomy because she has a spondy at 7-1 or at 7-1. Just in case her hand, get an EMG, obviously. But if she has like a C8 radiculopathy, I'll do a foraminotomy too, in addition to a laminectomy at C7-T1. So C2 to T2, laminectomy C3-4, and laminectomy C7-T1, and the foraminotomy on the ipsilateral side where her hand weakness is at C7-T1.
Yeah. Okay. All right. It's going to have a lot of neck pain from that muscle dissection in the back for sure. So Dr. Yam, David Yam, our good colleague from Oregon. So he's going the anterior route, C3 anterior route, C3-4, C7-T1 ACDF, and a new plate. Any thoughts on that? Would anybody go anterior here, or at least consider going anterior?
To be honest, no.
Now we have 2 votes in the chat box. We have 2 votes for anterior, guys. You're being outnumbered here.
Well, I think if you did go anterior, which is not completely unreasonable, I would definitely get an ENT colleague to help you with the neck dissection there, because the esophagus is probably going to be quite stuck in the situation. But the obvious benefit is staying out of the posterior part of her spine, right? It's going to be a much better tolerated surgery. You're talking about a patient that will probably go home the next day after these non-contiguous, skip standalone ACDFs, I think, as Jonathan had mentioned earlier, as opposed to a 2 to 2 posteriorly. So I think that is the enticing thing about going through the front. I probably, in my practice, would go through the back like what everyone else is saying. I think it's a more durable construct going from 2 to 2. The reason I would not stop at 3 is because you're going to be laminectomizing C3. So I always worry about buggering up the interspinous and supraspinous ligament to the roster level, and then potentially getting PJK above.
Okay, yeah, that's fair. That's fair. I think those are all great points, and I think I love the ACDF procedure. I really do, and I just for the reasons you mentioned, Michael. The patients are, for some of us who doing this for a few years, you could tell right off the back, right? Like your ACDF patients are going home, they're doing better, less phone calls, less issues. Posterior cervical patients are just having a lot of issues. But I had the same concerns as some of you guys. It's, getting an access surgeon, mucking around with that plate. If it was maybe just the C3-4 level, I think I would have 100% done it from the front with one of these, 0P, low profile adjacent segment disease implants. No question about it. The fact that she has a level below, I think that made me go posterior, honestly. And I'll show you what I did in a minute. But so, I have a rule, right? If you go down to T1, T2, just anchor at C2, because there are high failure rates. Just there's too much lever arm, too much stress at C2-3. And that's a true statement. On the flip side, at least in, my belief is that a lot of the pain does come from those muscle attachments at C2, C3, and you can do your best to kind of preserve them and whatnot, but in order to safely put in a pars or pedicle screw, I think you still need a little bit of dissection. So now I go, and I'm just kind of rationalizing this because this is what I did. Now I go with a preoperative alignment. If they have good preoperative alignment, either in the neutral position or they extend. I mean, if they're neutral or kyphotic, I'm not stopping below C2. This is C2 to T2 or even lower. But if they have a decent preoperative lordosis, or at least they're not kyphotic, they can reduce nicely. Sometimes I'll quote unquote cheat and kind of skip that C2 level and keep it for a revision. Let me put it that way. I know this talk is being recorded, and so I can't, I don't have too many pictures to show you because I really literally just did this today, so I can't say more than that because then it'll identify the patient. But I'm only going to show you the AP here. So this was my AP. I did C3. She was fused solid, so I wanted to. She was fused solid, so I wanted to save the healthcare system some money and didn't instrument every lateral mass. But I was worried about that listhesis. I was worried about the upper instrumented level, the upper part. So I did C3, C4 lateral mass screws, skipped 5, skipped 7, and then did T1 and T2. Completely agree with C2 to T2. I rarely skip C2, 3, but I just balanced it out with the patient and their neck pain and their preoperative alignment. But I felt bad. I felt bad opening up the whole neck and the back to treat, and I laminectomized those levels. I didn't do a full laminectomy. I just did the laminectomy of C3, 4, and C7, T1. So I don't know. Critique, shoot me down or tell me what you'd have done differently. Nader, any thoughts?
No, great, man. I agree totally. I mean, going posteriorly, the thing is like she has good cervical lordosis, so that's why a posterior approach is appropriate. She has good cervical lordosis. You don't have to reconstruct the anterior column. So, as I mentioned, if it's a C3-4 pathology, yeah, standalone anterior, I've done that. I don't like standalones below the fusion. I like them above. But yeah, I think that's. I would have done this.
So Nader, let me ask you this. Let's say C3-4 was not an issue, perfectly okay. I just want to piggyback on what you just said. Let's say her problem was only C7, T1 with stenosis and listhesis. What would you do?
Posterior decompression fusion.
Like C5 to T2.
C5 to T2 overlap with the previous fusion. Yeah. Plus, man, the angle here to C7, T1. See that angle too? Like how it's angling up. It's just too much. So yeah, I will go posterior.
Okay. Matt, critique me a little bit. You're adamant about C2 to T2, and I don't disagree with you, to be honest with you. I talked myself into not including it, but you're right. She's old, weaker bone. What do you think? Was this a mistake? Am I going to come back for a 2-3 ACDF pretty soon?
I don't know. I sleep better going to 2. I mean, I laughed hearing your thought process because that's what I feel like I go through, and I've stopped some at 3 and not gone to 2, thinking and then I always worry about it. So no, yeah. I think it's probably going to be fine. Those lateral mass screws, when I do it, I always worry that I'm not, I just love those C2 screws.
Yeah.
And I, worry about lateral mass screws, but
I've definitely been burned before. I've been burned before because I've taken patients who are either neutral or kyphotic and cheated a little bit at top and took some shortcuts. And I definitely paid dear price for that. I feel like if the patient has, decent alignment, either on neutral or lordosis, maybe they can tolerate that. But I may be wrong. I will promise to keep you guys posted. I'm not gonna. I don't run with my cases. I'll show you the complications. As you guys all know, complications are like our favorite topics here on Virtual Spine. So we'll bring it back. Michael, would you agree with that? Would you have done posterior, top to bottom?
Yeah, I would have done C2 to T2. The only issue I've ran into is if you're going to be decompressing at your top level, and that's also the top level where you instrument, because the spinous processes are so condensed in the cervical spine as opposed to the lumbar spine, for example, it's very hard to do an intralaminar decompression at that level or do like a dome laminectomy, if you will. So I've ran into issues where you inadvertently bugger up the facet above, or you take that interspinous ligament above as you're trying to do the laminectomy at C3, and then the patient will fall over, you know, half a year down the road. I don't know if any of you guys have ran into that before, but I've seen that a couple of times though. So
yeah,
I
that's a great
try
point.
to instrument the level above where I do a laminectomy.
That's a great point, and that's classic teaching, I think, right? Like if you laminectomize C3 to 6, you know, you may want to consider fusing a little bit longer, but and you know, everybody's technique kind of you know, kind of gets fine-tuned and modified in your own practice. But yeah, I don't take all of C, like here, I didn't take all of C3. I took the bottom half. I'm kind of working at a corner, right, at an angle, because you're right. Otherwise, you're taking all of C3. And I'm 100% keeping the C2, C3 interspinous ligaments and attachments together. But if you're going to do a complete C3, which you basically have really compromised the C2, C3 posterior tension band, I mean, you're done, right? You're done. You might as well just instrument to C2. Again, maybe me talking me out of it, but you know, just because I stopped at C3, I didn't do the same laminectomy I would have done if I were going up to C2. Does that make sense? At least, you know, at least that's how I do it.
Absolutely. I mean, that makes complete sense. Yeah.
Ali, do you think they have less, or any of you guys, do you think they have a lot less pain when you don't take down all those posterior attachments at C2? I mean, I feel like they should have less pain. Whenever I do this, I feel like it's the same.
I agree. I think it's the same whether you take the C2 ligaments down or you're stripping everything from 2 to 7.
Probably is, you know, it probably is the same, but you know, the reality is that the way the suboccipital triangle is and the muscle attachments to C2, it's just, you just have more bulky muscles attaching to the C2 spinous process. So I think, you know, you could make the argument that the more muscle you take down, you know, the more pain, but I don't know enough about that. Nader, I want to ask you a question since somebody asked a question here. Naif asked a question to you directly. Why would you consider the standalone above at C3-4, but not below a construct?
Oh, yeah, because you know it's you're asking too much from that device biomechanically if you're putting it below a long segment fusion. You know what I mean? The likelihood of it failing is higher because you have a long segment fusion and then you're putting the standalone device below it. So there's definitely higher likelihood of subsidence, dislodgement, and all that. So you're asking of it more than what it's supposed to do. But going up, you know, there's, you know, it's less of an issue because you're not working against a bigger lever arm above the device. So yeah.
That's just your technique of not liking.
Yeah. Not below the long segment fusion.
Yeah, I don't think I disagree with that. Well, we're coming up to the top of the hour here. Thank you guys for humoring me and looking at some of these cases and discussing the good, bad, and the ugly. I really appreciate it. Again, we have some exciting stuff coming up for the new year. We do have one more session for this year, though, and then we're going to take a couple of weeks off for Christmas and New Year's. The Thursdays end up being the New Year's Eve and Christmas Eve. So for the sake of families and loved ones, we're going to take a break. I think you guys, I know a lot of you appreciate it, but it's really a lot of work to do this every week, week in and week out. But we love it. We're happy that everybody's with us. Nader, Dr. Dagdale, you're in charge of next week, which is the final week for the 2020 year. Good riddance in that respect. Who's our guest next week?
So our guest next week is Dr. Brian Deluhi. He is a pediatric neurosurgeon at the University of Iowa, and he's a CVJ expert. He works with Dr. Menezes, and he's an expert in CVJ. So he's going to show us pediatric craniovertebral junction cases. Pretty interesting. And that's how we're going to end up the year. And we're looking forward to hosting him.
Great. That's fantastic. Listen, that's a great topic. And I know you've shown a lot of great adult cases. So maybe he can bring in some pediatric cases as well. So we see maybe some both adult and peds CVJ cases. Okay. Thank you, Nader, Michael, Matthew, Jonathan Rasuli. Thank you guys all today for being here, and have a great week. We'll see you next time. Have a good night.
Guys.
Good night. Great cases. Thank you.
Yeah, great cases.